How's it going, guys? Medium difficulty question for cardio. We got a 9-month-old boy who's got tetralogy of Fallot, and we know that because we've got cyanosis that improves with squatting. Now, tetralogy of Fallot, which is pulmonic stenosis, right ventricular hypertrophy, overriding aorta, VSD, can occur standalone. It can also occur as part of the 22q11 deletion syndromes, overt DeGeorge syndrome, or velocardiofacial syndrome. But it's going to show up mainly two ways in USMLE. 12-year-old boy who's squatting on the soccer field to improve oxygenation, mechanism I'll talk about, or it can be a child under the age of 1 who has what's referred to as a TET spell, T-E-T spell, where there's worsened hypoxia / cyanosis with crying. So what's the mechanism for the patient's TET spell in this case, which, by the way, the systolic murmur is the combination of the pulmonic stenosis and the VSD, and this is how NBME can describe it with tetralogy of Fallot, just a harsh general systolic murmur at pretty much any location on the sternal borders. So choice A, decreased pulmonary vascular resistance, is wrong. Two reasons it's wrong. Number one, crying mostly increases pulmonary vascular resistance acutely due to increased sympathetic activation. The second is, even if we have no idea what's going on, choice A is a possible explanation for how we could have a mitigation rather than exacerbation of cyanosis. Because if you have a right to left shunt causing cyanosis in tetralogy of Fallot, if you decrease pulmonary vascular resistance, you're decreasing right-sided heart pressure, which should theoretically mitigate your right to left pressure gradient. Choice A, wrong fucking answer. Choice B, increased vascular resistance, wrong fucking answer. In fact, that's the mechanism for how squatting improves the cyanosis acutely, because squatting will significantly increase afterload on the left ventricle, increasing left-sided heart pressure. And if you're increasing left-sided heart pressure, you're decreasing the degree of the right to left pressure gradient, thereby mitigating that right to left shunt. Wrong fucking answer. Choice C, sudden increase in left ventricular oxygen demand, is wrong, because even if that is occurring in the setting of increased sympathetic activity, it's not the mechanism for the cyanosis itself. Choice D, sudden increase in right to left shunting across the interatrial septum, is wrong. Slightly audacious because we don't have an ASD, and I've never heard of USMLE assessing a theoretical Eisenmenger or a situation in which an ASD will be cyanotic. Okay, it's only going to be VSD scenarios. Choice C, correct answer, worsening right ventricular outflow obstruction. TET spell is a very obscure mechanism. There's something called the infundibular muscle, which regulates right ventricular outflow. And in the setting of crying, where we get increased oxygen demand on that infundibular muscle, you can get acute reduction in right ventricular outflow. Okay, so you get RVOT, right ventricular outflow tract obstruction, that's worsened in the setting of a TET spell. Sounds obscure, but it's assessed on NBME and especially the pediatric stuff for 2CK. But for step 1, I mean, you got to know the physiology and tetralogy of Fallot and all this stuff anyway. So 2 points in recapitulation here. Number 1, you got to know that for tetralogy of Fallot, your 2 presentations are 12-year-old boy squatting on the soccer field. Your second presentation is a TET spell in a kid under the age of 1. And then you got to know that it can be, tetralogy of Fallot can be part of the 22q11 deletion syndromes or just standalone. If you know the deal, and to make more content, subscribe to my channel. Appreciate your time. That's it.